you are freezing your eggs in time. If you froze your eggs at 25, they remain at 25. So you have two directions, whether you have to achieve a career first and then think about the child. While this is happening, you might really miss the boat. The woman has two ages, we say, the chronological age is her age, 36, 37, 40, whatever, and there is an ovarian age.
I would love to have your standpoint on why more and more people struggle with fertility these days versus 50 years ago. Hello everyone, welcome back to the Eat, Burn, Sleep podcast. I'm so excited to be here with one of the leading fertility doctors in the world, Dr. Rami Wakim, who's based in London and has given me the chance to interview him today. We have so many people who are looking to conceive or thinking about having children maybe later in life, and we're going to be discussing all of this. Fertility issues have been on the rise. It's been a problem worldwide, not just in the UK and the US. And we're going to be talking about how to optimize as well the state of your body when you're preparing to have a baby. Let me tell you a little bit more about our fabulous guest. Rami Wakim successfully obtained his membership to the College of Obstetrics and Gynecology in 2000, followed by double fellowship programs at the University College London Hospital and the Imperial College in London. Over the course of 25 years, he was fortunate to work with the leading professionals in the field of reproductive medicine and in some of the busiest clinics, including ACU UCH, IVF Hammersmith, Assisted Reproduction and Gynecology Center, ARGC, and also at his own practice in Harley Street.
Oh.
I have with me the amazing expert, Dr. Wakim. Thank you so much, if I may call you Rami, for being here with us today.
Of course, thank you very much for this kind introduction, and I'm very pleased to be here and to answer all the queries that the patients can have and enlighten about the field of actually reproduction and how it became more and more advanced, and with some new technologies emerging that can help into really pushing the boundaries for success.
I've always taken an interest in fertility, not when I was very young, because I was lucky to conceive my first children quite easily, but suffering from inflammatory issues, I suffered quite a few miscarriages afterwards, which made me think about the problem and then, create a whole section on my platform on it. But before we go there, I would love to have your standpoint on why more and more people struggle with fertility these days versus 50 years ago.
So basically, don't forget that lifestyle has changed a lot. And stress, whether at work, whether the circumstances that you go through, and challenges in life, at work, that can push you to wait and postpone your fertility potentials. So you have two directions, whether you have to pursue the PhD first or you achieve a career first and then think about the child. While this is happening, you might really miss the boat. Sometimes this is affecting without even the knowledge of a basic investigations that we are going to talk about, which is the fertility MOT, that could help a lot into anticipating whether I could wait, I could not wait, stuff like that. Normally, the woman has two ages, we say, the chronological age is her age, 36, 37, 40, whatever, and there is an ovarian age. And in most of the cases, they are compatible with each other. So when you have a 25 years old girl, she has also a 25-year-old. Means what? Means the ovarian reserve is high, the quality of the eggs is high. I have to consider two parameters in assessing the ovary and assessing the condition of the egg itself. Is it the number, which is the quantity, which is the ovarian reserve that we are going to talk about, and also the egg quality, which goes hand in hand. Until now, the only parameter that we cannot beat, actually, because nature is more powerful, is the age. So the age is directly proportional to the egg quality. The younger you are, the higher is the quality. the older you get, the less quality. And this is by nature, and unfortunately, we cannot beat it. Unless, obviously, we can beat it with something called egg freezing. The egg freezing is, if you wish to define it, is it's like you are freezing your eggs in time. Say if you froze your eggs at 25, they remain at 25. So even if you use them at 30, at 32, you still behave as if your baby born and all the hormones that produced during pregnancy, like for nuchal test, for all these blood, you have to inform the people doing this scan or first trimesteric assessment that the egg was produced at 25, because the statistics remain at 25.
Coming back to this concept that you've just mentioned, of doing a fertility MOT, what is it exactly? Can you measure without going through the egg freezing process, what the egg quality is?
As I mentioned, the egg quality, unfortunately, we are not able to assess it, except the proof is in the pudding, as we said. Like if you get pregnant, that means you have produced a good quality egg, which led to a good quality embryo, and then you had the baby. So I'm reassured in that way. Very occasionally, we see under the microscope, if we are doing an IVF, the egg quality, so we can see the egg as the anatomy of the egg, whether it is a granular cytoplasm, if it is clear, if she has vacuoles, if there is anything abnormal. That's very rare. But what we rely on is the egg quality is basically depending on the age. That's number one. Second, the fertility MOT, which is kind of misnomer, or what I like to change to fertility check, basically, is something that we had started in 2002. Two factors contributed to this way of anticipating and checking for the fertility. One of them is that the freezing technique. The freezing technique has changed in 2002 when I was at UCH, and we used to know that the freezing methods were mainly cryopreservation. That means freezing. It's basically like people think like it is like a freezer, like you put your embryos there or whatever. But when we changed this to a technology called vitrification, and this was a Japanese technology, and vitrification gave us this luxury of freezing without the complications of the thawing. The problem was with the thawing. When you thaw an embryo, there was ice forming. It's exactly when you take things from the freezer and then you see that during the melting procedure, there is ice particle form, and this harms the embryo. So out of, for example, like 10 embryos, maybe 7 will survive, maybe 6 will survive because of this ice particle formations. With the vitrification process, it's an immediate freezing. So it literally solidify as if glass. That's called vitrification, as if like glass. So when you thaw it, there is no ice particles. And this was magic.
Amazing.
So this was a big contribution in order to achieve what we are going to achieve. I'm giving you just the history, how it elaborated. So this is the first thing. Second was freezing the egg itself. The egg was a very difficult cell to freeze. We freeze embryos, as you know, we freeze sperms, easy. But the problem was with the egg. The egg is a hard shell and it's very difficult to freeze. Again, we realized that there is a technology through the vitrification made it possible that we can freeze eggs. And this was around 2002. Since then, combining these two components that we can freeze eggs, we have a new technology in freezing. And the third was the AMH, which is the anti-Mullerian hormone discovery. I was fortunate enough to produce one of the first papers on AMH and at UCH. And this was basically, we realized that the AMH is produced by the granulosa cells around the egg and the cumulus, what we call the cumulus cells. So that means, in simple terms, the more AMH you have, it reflects a higher number of eggs, as simple as that. So if this is directly produced by the eggs, that means that if I can actually have an access to this AMH, and it was fortunate enough that it is a blood test. So the blood test we just do, simple blood test, and it gives me a number. And originally it was in nanogram per mil, and eventually then we shifted to picomole per liter. And the reason why the nanogram per mil is a short bracket means the normal is between like 1 and 4. Mm-hmm. So you don't have like 2 is a good or bad, or 3 is it like what. So when we change it to picomole per liter, it gives me a wider range. So you can see, say, the normal range would be from 4 to 78. And then any kind of number in between is the ovarian reserve quantitative as to how high or how low, or how average it is. I like to compare this with the analogy of a fuel tank. So when you have a fuel tank, because a lot of people think that, my AMH is 14 or 40 or what? How do you assess? Is it that means I have 40 eggs remaining? No, it's not. It's like the fuel tank. Obviously, if you have on the maximum value, so that's a full tank. Okay, so if you are like average, like mid tank, or low, or above average, or very low, when it becomes red or flushing, that means low or very low. Unfortunately, in the human body, it's not like the car that we can just go and fill in the petrol again to renew or to replenish the AMH. Unfortunately, we cannot do that. However, this could be the red flush that as if like your ovarian reserve is low, then we can do something. And what is this something? Not to go to the petrol station to fill it. We can do egg freezing. So save the eggs as early as possible, and as soon as you have this info. So I'm giving you the chronology of how it happened. So at the same time we had the AMH discovery, at the same time we had possible to freeze the eggs because we discovered something called vitrification. So all together became very, very practically useful to think about, fine. So if I have this possibility to know and quantify the quantity of the eggs that you have remaining, because we know is by nature, by age, the decline goes from puberty to menopause. Some people gradually decline, have this decline in a very gradual way. Some people have sharp decline. Now, it could be iatrogenic, means you remove one ovary, something happened, you remove a cyst, or you had complex endometriosis surgery that involved a lot of debulking of the ovarian cortex. These are the kind that affect the reserve. Naturally speaking, some women can have this kind of precipitated or a very, very sharp decline for genetic, familial, we don't know what. So what is the outcome of this is that at least we can get away with this situation by freezing what we can from what is left.
For women trying to assess their fertility, they would go through a test to try and assess the AMH?
It's a simple combination of a scan and the blood test.
Brilliant.
That's what we call the female fertility assessment or female fertility MOT. The scan is to look at the antral follicles. The antral follicles, like you can see them on the ovary, and it's like black blobs in the ovary. You can see them. We didn't know before, like, what was it? Like someone has like a lot of these black blobs, someone doesn't have, and then started questioning what could it be, what could it be, and then it turned up to be like, yes, these are the antral follicle that I can measure. And obviously with the scan machines technology and advancement, so if I'm talking about the days of the 60s and 70s, they were very, very kind of naive, like as technology wise, and there is no sharp definition. If you see Louise Brown or whatever, these the scans of how it was, the ovary and the egg, and you compare it to what we have now, it's beyond your expectation, because the capability of the scan machines now are very sophisticated, and the definition of that you can see the antral follicles, what we call between 2 and 6 millimeter in size. That's an achievement, you know. So you can easily detect these antral follicles on both ovaries, and then you get what we call the total antral follicle count. And it should coincide or compare to the AMH. So we do the AMH in case subjectively there is a bit of discrepancy between one sonographer and the other. I can say maybe 10 antral follicle, another colleague can say 8, another one can say 12, depending on the parameters he has in head as to what exactly is that 2 to 6 mils, or is that 2 to 8 millimeter? Shall I include the 9 millimeter or not? And the scan machine itself. So the higher the scan machine, obviously now we are using what we call the Rolls-Royce of scan machines. It's a very famous brand, and it does the job. So it makes things easier. Together with the AMH. Usually you compare it and it matches. If we are spreading this into a what we call couple fertility MOT, that means we just add semen analysis.
Yeah.
Okay. So how many times we have seen surprises from on the male side just simple tests, semen analysis, very easy, and then you see like the number, you look at the motility, you look at the morphology, and surprise, surprise, you can see like some cases that need urgent attention, which they didn't have in mind. They were thinking like just to wait another 3 years or 2 years.
I remember reading this stat about 40% of couples who struggle to conceive are due to male fertility, but there's this big taboo where we can talk about the female infertility, but male infertility is still really taboo.
It is in a way, and it depends on the culture as well and the background, and obviously this is a very sensitive issue for some men, but obviously more and more now I see like people like talking openly about it. There is no this kind of being hesitant or whatever. They just speak frankly about it, which is really something good. I really encourage everyone to do that, because it opens up, like some people would be shy, for example, like to ask, and then when they hear someone else, I've done like 1 IVF or 2 IVF and it was successful or whatever, maybe then she gets encouraged.
Yeah.
So the semen analysis, as I said, it's a very simple procedure, but at least it gives me like a hint of what is normal, what is abnormal, and we can therefore trying to avoid this problem of ignoring an abnormal result for too long. And this is essential in the male parts. As I said, third is male, third is female causes of I don't like to call it infertility, it's subfertility now.
Yeah.
We stopped saying infertility, okay? So the good news is that there is nothing called infertility now, except maybe one odd occasion when, say, there is no uterus, for example. That's infertility. Okay, fine, I get it. But still, with there is a possibility to achieve your dream of having a child through surrogacy, through something else. But the term infertility as absolute, there isn't anymore. It's subfertility, and we have to detect it. And the third, the remaining, is unexplained. Luckily enough, by pursuing more and more research and getting into the right diagnosis, we are able now to shrink this third 30% into less and less. So now we are talking about maybe 20 or 15% that are still unexplained. Okay, so when you assess a patient, the most critical thing you need to achieve is to have a proper diagnosis. A lot of people just go on and on and on for years without diagnosis. But once you achieve a diagnosis, that's when you start on the right track.
You've just said so many interesting things. I'm going to go back on a few points. The first is I love the term of subfertility because there's no such thing, you're right, as being unhealthy. It's not being at optimal health level. So we're just trying to get from a place of less performant to more performant. And it's great to think of a spectrum like that, of being subfertile or suboptimal, whether it is from a fertility standpoint or immune system standpoint or mental health standpoint. And that's a great way of approaching it. The first thing you mentioned when you were talking was the timing and how our lives have changed. And it's true that we say that women can have it all. We can, but just not all at the same time. And for us, as you said, to pursue a PhD versus having a child in our 20s is we can't be in two places at once. And thankfully now technology allows us, through all these tests that you've just mentioned, the blood test and the scan, to assess exactly where we're standing, how much time we have. And there is this option to now freeze these eggs, our eggs, in a very efficient manner.
And I can give you even more good news that when I started offering this, actually, it was a research basis, and we quoted just 10% success rate, and we only basically offer this to people between 25 and 35. Now we became very lenient. Okay, now we pushed the boundaries to say if someone is 38 and still has got a good reserve, so why not? We can. 40, 41, done so many cases at 41 that she wanted to have freezing. However, there is only one thing you should consider. Obviously, the sooner the better, the younger the better, because of the egg quality. When it hits 40 and above, the egg quality comes into the equation. So it's a balance. However, we can maybe push our boundaries by getting more eggs. So initially, the statistics were if we got 12 eggs at age of 30 to 35, we have almost 50% live birth rate. That was the statistic. So long we achieved 12 eggs. And that's why we pushed to say that let's restrict this to people from 25 to 35. But when it came to 37, 38, we were wondering if they are going to give us the same kind of statistics. Yes, similar statistics, maybe on the lower side if they are above certain age. However, if the number is low, then we can beat it now by repeating cycles. So there was only a concept of one cycle that you can get 12 eggs or whatever, you push to the maximum of injections in order to get the highest number of eggs. Now, if someone produces only 4, 5, shall we tell her just forget about this? No, we can offer now package. It's called 3-cycle package. I'm sure you heard about it maybe. 3-cycle package means we can try once, twice, 3 times, collect the eggs and then bank them. So maybe I will obtain 4 from the first, 6 from the second, and then 3 from the I have 13 eggs at the end. So if she's willing, if there is the money, because still it's not NHS funded, because it's considered as luxury. It's like to freeze your eggs. And that's what we used to call social egg freezing. So if you have the, possibility to do it, then yes, do it. Some people go beyond even 3 cycle. I'm not mentioning this.
I feel compelled to actually share a personal story I've never shared publicly before, which is, so I had my first child at 29. No problem. Second child at 31, no problem. This I have shared before. Then I unfortunately suffered some miscarriages because I was very inflamed from 2 autoimmune diseases. And in the second part of this podcast, I'm going to talk about how to de-inflame your body and really optimize fertility. But I got divorced around 10 years ago, and I decided to freeze my eggs to give myself an option if I wanted to rebuild a family one day.
Okay.
So I was 36 years old. And I went to a doctor in London who has now retired, but I'm sure you've come across him. And we did 2 cycles. And it was a great experience for me because it allowed me to also create a protocol to recover from all the hormones that are injected into you. Because for a woman, it's very hard to recover from that. And I've created, it's part of the liver detox actually on the platform, but I'll talk about that later. And in 2 cycles, he managed to get 23 very high quality eggs. And he couldn't believe that.
Yeah.
At 36.
Cycles to cycle variation. So you can get like maybe 6 from one cycle, maybe 10 from the second cycle. Every cycle is different. Why people get different eggs and different number of embryos from different IVF cycles, even spaced 2-3 months apart or 6 months apart. That's because of this, of variability of the hormones that can get you the maximum or the minimum number of eggs, depending on the sensitivity of the follicles to the medication itself as well.
And would you say, because I remember he was like a bit of a crazy doctor, and at the first assessment, he said to me, well, if your eggs look as young as you do, then we'll have good results.
That's right.
He was saying this. And then when this happened, he said to me, we did, the majority of the eggs we got were high quality, and he knew my history of ulcerative colitis and autoimmune hemolytic anemia, and I had been on steroids, immunosuppressants, and biological drugs. I mean, I was just out of a health nightmare. I just got into remission, and he asked me about what I did to stay in remission. And I said, do you have time? He said, yes. I said, okay. So we sat down in his office and I talked him through what I share now on my platform. And he went and researched some elements of it where he changed his habits because he found that some foods he was eating regularly were aging him faster, that were on my red lists. What I wanted to ask you is, from your standpoint, we know that changes in lifestyle can improve a fertility rate, but would you say that changes in lifestyle can improve egg quality? Thank you for listening so far. We'll be continuing this conversation in part 2, so make sure you're subscribed to the Eat, Burn, Sleep podcast so you do not miss it. In the meantime, for those of you who are not members of the platform yet, we have a discount code for all our podcast listeners. You can get 15% off all Eat, Burn, Sleep memberships. Just enter the code podcast15 at checkout on the memberships page on eatburnsleep.com. We still have so much more to cover, so please stay tuned.